So we're going to start the forum with the fantastic speaker, AmandaCastel, who spoke at last year's forum, and this year is going to present on what works to reduce HIV-related stigma and discrimination and how this can apply to COVID-19. Amanda works at the George Washington University in the United States, where she is professor in the Department of Epidemiology and Biostatistics. She has a really good track record of looking at and conducting studies in technology-based interventions aimed at improving and indeed have improved HIV testing, engagement in care and treatment adherence.
Hello, I want to thank the conference organizers for inviting me to give this talk. Over the next few minutes, I will provide a brief overview regarding the novel coronavirus pandemic and responses, discuss some of the stigma and discrimination that has resulted in that response, highlight the synergies between COVID-19 and HIV, and discuss how our experiences with HIV-related stigma and discrimination can inform our responses to the COVID-19 pandemic. It's hard to imagine that only 10 months ago, a pneumonia of unknown origin was detected in Wuhan, China. The Chinese government acted relatively quickly with identification of a novel coronavirus within 7 days of detection. And by January, a public health emergency of international concern was declared by the World Health Organization. By February, the virus had been identified as COVID-19, and in mid-March, the WHO declared a global pandemic. As of today, there have been more than 50 million cases of COVID-19 reported globally. The distribution of the virus globally has disproportionately impacted some regions of the world more than others, including the Americas and Europe, as you can see here in this graph. Interestingly, the African continent has been relatively spared compared to other regions of the world, with approximately 1.3 million cases reported, or about 2.5% of the global number of cases. The response to the COVID-19 pandemic has relied on several traditional public health approaches, including containment strategies such as contact tracing, isolation, and quarantine. Strategies which have been used with other infectious diseases such as HIV, sexually transmitted infections, and Ebola. However, as the transmission rapidly outpaced containment efforts, we've really focused also on mitigation efforts, including the development of non-medical interventions, as well as application of non-pharmaceutical interventions such as school closures and social distancing. All of this has been implemented with the goal of flattening the curve to minimize the overall number of infections and spread, and to protect healthcare systems from being overwhelmed. So how have these efforts resulted in the emergence of COVID-19 stigma and discrimination? Well, more specifically, COVID-19 response efforts have included restricted air travel and closing of borders, issuance of quarantine and stay-at-home orders, as well as social distancing, closure of schools, universities, and non-essential services, and establishment of surveillance systems and contact tracing workforces, as well as testing and expansion of testing for COVID-19. And while the rapid implementation of these efforts was successful in curtailing the spread of the virus in many countries, it has also had what some might consider to be unintended consequences. For example, closing the borders resulted in xenophobia, racism, and discrimination. The quarantine and social distancing orders resulted in many persons being socially isolated and lonely, disruptions in the receipt of care, and importantly, the propagation of mis- and disinformation due to a reliance on social media during these lockdown periods. By closing educational settings and non-essential services, younger people were likely protected. However, this meant that essential workers, who are often the most vulnerable and socioeconomically disadvantaged, were still required to work and were put on the front lines of the pandemic. And public health measures such as contact tracing resulted in further stigmatization, reluctance to share important information with health officials, and testing expansion and access was often unevenly distributed. further exacerbating inequities in healthcare access. So these consequences are not novel to the COVID-19 pandemic. As the World Health Organization describes, often in outbreak situations and epidemics, people may be discriminated against because of a perceived link with the disease. The stigma around COVID-19 was likely worse because it was a new virus, and we didn't know much about how it would affect people, and that results in fear of the unknown. And as we often see, that fear then gets translated into a disease being associated with others, resulting in social stigmatization, othering, labeling, and stereotyping. Stigma interacts with underlying racism, ageism, cultural differences, sex and sexual orientation, health status, poverty, and many other structural factors. And as a result, we observe barriers to testing, less health-seeking behaviors, and therefore poorer health outcomes, including mental health. So as I've mentioned, what we're observing with COVID-19 is not unique, and it's not new for those of us working in the field of HIV. In fact, there are quite a few synergies between the two viruses. Many of us in the field are starting to reflect on this. And as you can see, these are just a few articles highlighting the synergies between HIV and COVID and how we might learn from these past experiences with HIV. As we've learned more about SARS-CoV-2 or COVID-19 and how it interacts with HIV, the World Health Organization and other governing bodies and organizations have issued interim recommendations and guidance on management of people living with HIV during COVID. What we are still examining, however, is the impact of the pandemic on the HIV care continuum, a topic that will be discussed in depth at a later talk. While there are still many unknowns, this table attempts to summarize and compare some of the key characteristics of COVID-19 and HIV. Virologically, we see commonalities between the viruses, including animal hosts, high numbers of infections and deaths, and high mortality rates. However, we've seen a distinct difference with respect to mode of transmission, incubation period, and symptomatology, as well as the overall geographic burden and distribution of disease. Importantly, neither virus has an available vaccine currently. Thus, identifying those most at risk and instituting prevention efforts are key to epidemic control. We see that prevention of COVID-19 has taken on a similar approach to that of HIV, with testing, contact tracing, and behavior change being key strategies. It's also important to acknowledge that there are shared experiences with respect to these two pandemics. These include acknowledging the essential role of testing and diagnostics among those most at risk, the need to implement robust surveillance systems and employ techniques such as contact tracing to curb the spread, and the challenges associated with developing effective therapeutics and vaccines, and importantly, addressing the severe social and economic consequences of the virus, as well as fighting the stigmatization and criminalization that is often associated with the new disease. The figure on the left here is from Shao et al. And highlights the psychosocial and structural burdens of the syndemic health problems between HIV and COVID-19. One key distinction between the two epidemic responses has been that of time. So misinformation is defined as information that is false, but which may be believed by the person spreading it to be posted in good faith. Whereas disinformation is the false or misleading information that is spread deliberately to deceive others. When HIV was first identified in the early 1980s, there were many unknowns which resulted in mis- and disinformation. As you can see here, people argued that HIV did not cause AIDS, and there were even Russian KGB disinformation campaigns arguing that HIV had been created by the CIA. There was also misinformation about the role of treatments, which we've seen with COVID-19, with debates about the effectiveness of hydroxychloroquine for COVID-19. So with the COVID-19 pandemic occurring during a highly digital era, we've also observed the pervasive spread of disinformation regarding theories that COVID-19 was spread by 5G cell phones, that it was intentionally caused by Bill Gates to sell the world a vaccine, and even the use of social media to discredit world leaders such as what happened in Ghana with President Akufo-Addo. So given this context, social media and digital news further propagate the mis and disinformation, resulting in xenophobia, racism, discrimination, social stigmatization, and exclusion. For both epidemics, the novelty of the virus has led to uncertainty and finger pointing. Even if you look at the naming of the viruses, with HIV, it was initially called gay-related immune deficiency, and the focus on 4 key populations led to further ostracism and discrimination of these populations. Similarly, with COVID-19, people have often referred to it as the Chinese virus or Wuhan virus, despite WHO naming it COVID-19, and people who were infected with COVID were often referred to as super spreaders. And importantly, both viruses, we still see criminalization and legal action being taken against people who transmit HIV to others. We still have 72 countries in the world that still have legal laws on the books to enforce criminalization of HIV. And as we've seen with COVID-19, we've heard numerous accounts of people who are not following public health measures being unduly persecuted. So what can we learn from our almost 4 decades of experience with HIV? Well, UNAIDS has taken the body of evidence from HIV regarding evidence-based interventions for reducing stigma and discrimination and applied it to the context of COVID-19. They proposed that all of the proposed actions taken to curtail stigma and discrimination as it relates to COVID-19 be rights-based and community-led, with special emphasis on populations that are being left behind. The recommendations fall along these 6 key areas listed here, and a wide range of activities, including developing or modifying anti-stigma materials, providing PPE to families, communities, and healthcare workers, offering counseling, measuring stigma systematically, developing non-discriminatory workplace programs, ensuring fair access to financial support programs, implementing strategies to facilitate learning while reducing existing social and racial inequalities, establishing differentiated models of care delivery, using science to actually inform and educate constituents, and providing legal assistance to those in need are just some of the recommendations that can be found in this document. Other solutions worth mentioning include ensuring broad community engagement and support. That might be in the form of identifying and educating key opinion leaders, which we know works with HIV, or using social influencers to interrupt the dissemination of mis and disinformation. We can also ensure that as effective vaccines are identified, that the community is at the table working with scientists and politicians to figure out how to best disseminate and get access to those vaccines. We should also strive to be intentional with our language, as we try to do with persons living with HIV. And we can partner with people who've been affected or infected with COVID to dispel the myths and to speak to the truths of having COVID-19 and surviving. So in sum, the coronavirus pandemic is an evolving situation that's had unprecedented global impact, but disproportionate impact on certain populations and regions of the world. The unknowns and uncertainty, given the novelty of the virus, have led to stigma and discrimination that's similar to that we've observed with HIV. And therefore, we have to capitalize on our knowledge from prior pandemics and epidemics to try to systematically address these racial disparities, stigma, and discrimination. HIV provides many examples of how to confront and reduce stigma and discrimination with COVID-19 and other infectious diseases, and can lay the foundation for that response. So with that, I thank you for your attention, and I look forward to the discussion.